So you're all here, so you all have some awareness of this problem. And the title, A Question of Balance, the subtitle, is a question I'm going to come back to at the very end. So we're looking at an unprecedented rise over the last 10 to 11 years in unintentional prescription drug overdose deaths. That's why we're here. So we're going to look at the scope of this problem, and we're going to look at how the problem got started and why it's been so difficult to, why it's been so refractory. The problem continues to get worse, in fact. And then we'll talk a little bit about what we can do about it. So let's look at the definition and scope of this issue. So we're talking about unintentional deaths here. Unintentional injuries are the 5th leading cause of death in the United States. These are numbers from 2010, 2011, the most recent numbers. You'll see here accidents rate number 5. The principal sources of accidental death are motor vehicle accidents, falls, as in fall off a roof, and drug poisoning. Notice that intentional self-harm rates down at number 10. So, for a long time, motor vehicle accidents, as you would imagine, were the dominant source of accidental deaths. But around the year 2000, an unusual thing started to happen, and that is there began to be a steep escalation in poisoning deaths, and in particular, drug poisoning deaths. So that by the year 2008, drug poisonings had surpassed motor vehicle deaths. Unprecedented in the United States. So we're not talking about just any drugs, we're talking about prescription drugs, also unprecedented in the United States. The decade of the 70s and 80s were dominated by illicit drugs, and since the year 2000, there's been an explosion in the death rate associated with prescription drugs. So what prescription drugs are we talking about? Well, logically, you would think it's going to be the most commonly abused prescription drugs, and that is largely true. There are 3 principal commonly abused drugs: the opioids, the benzodiazepines, and the amphetamine-like drugs. The opioids are the pain reliever drugs: oxycodone, hydrocodone, fentanyl, methadone, morphine, codeine. It's a large group. The benzodiazepine group is the Valium family, of which Xanax and Ativan are well-known drugs, especially Xanax. The amphetamine group is the group that's used to treat attention deficit hyperactivity disorder. This group is not a drug toxicity problem. This drug, in fact, when you look at the mixtures of drugs that are showing up on autopsies, these prescription amphetamines aren't even on the list. So the 2 groups we're talking about are the opioid group and the benzodiazepine group. So again, the opioid group is the same as a narcotic painkiller. And I'm going to use the word opioid because it's easier to say than narcotic painkiller. And it's easy sort of to remember because morphine is the prototypical opioid. It is derived from the opium plant. Hence, the name of the entire family is opioid. This is the family of receptors that all these narcotic painkiller drugs act on in the brain. So, of these 2 drugs, the opioids by far are leading the way in terms of unintentional deaths. So almost inevitably, when a patient dies from drug toxicity, it's from a combination of drugs. Alcohol is often involved. There may be illicit drugs involved. But what we're seeing in the mixture over and over again, in fact 75% of the time, are the prescription opioid group. The benzodiazepine groups is showing up quite a bit also, but nowhere with 3 times less than the opioid group. So we're going to talk in just a minute about what makes the opioids such a special group of drugs. So how did we get into this mess? I, in fact, was practicing anesthesia, and we had a very active inpatient pain service. And in the year, back up for a second. So I take you back again to the year 2000. In the year 2000, a very powerful hospital organization called the Joint Commission began to push for more aggressive treatment of pain with opioids. Pain was labeled the 5th vital sign. These, what do you call the things you pin on thing? Tag thing. What's the word? Button. Thank you, button. See? It's been a long day. These buttons were being worn, particularly by floor nurses, and the whole concept was promoted that if you've had surgery, you should not be in pain. You shouldn't have to tolerate pain. This is why we have opioids, and we should use opioids more liberally. And it wasn't just the Joint Commission. Several medical organizations were behind this, and particularly pain organizations. The media got in on the act, and I didn't include this in here, but drug companies, of course, got in on this, and they started promoting heavily both to doctors and directly to patients. Naturally, this occurred in what was a weak regulatory environment because nobody had really thought about the consequences that, of course, now seem very obvious. And I remember at the time thinking, bells were going off as I was seeing all these no pain signs, like this is not going to work. This is not going to be good somehow. And so at that time, around the year 2000, very few medical state boards had rules and regulations targeting prescription opioids. There's virtually no legislation targeting pill mills, and there were very few prescription drug monitoring programs. As it stands now, Georgia has 2 out of 3 of these. We do not, as of yet, have a drug monitoring program, which is very unfortunate because it puts doctors in it's an essential tool for doctors. So what we saw was then a very sharp rise in opioid prescribing, really without an adequate discussion of the consequences for the individual and the consequences for society at large. So the dotted line here is opioid sales. Again, around the year 2000, you see an explosion in opioid sales. The solid line right beneath, which tracks it perfectly, is the death rate. So sales, death rate, direct correlation. And this is an important point. You see here that a dangerous prescription drug, and I don't mean to imply that drug's not useful. I'm not vilifying the opioids at all, but they are a special class of drugs and they have to be used very carefully. When they are not used carefully and they are deployed indiscriminately into society at large, you're going to end up with this, where it rapidly outstrips cocaine and heroin. Why? Because it's deployed much more widely, permeates society much more widely than the illicit drugs do. So, what this has resulted in, if you look here for every death, there are follow this down, there are 825 non-medical users. So this means there has been an explosion in diversion. Diversion means that somebody is taking the drug for whom the drug was not prescribed. And when there is a glut of anything on the market, bad things happen usually. And when there's a glut of a dangerous substance on the market, this is what happens. The highest risk group, interestingly, and oh goodness, yep, the highest risk group is the 45 to 54-year-old group. The lowest risk group are the elderly. Well, I don't want to say elderly. 65. Sorry, I take that back. You didn't hear that. Boy, should I just quit now? The 65-year and older group and the 15 to 24-year-old group. So I actually had dinner last night with a well-known addictionologist who practices in the Gwinnett area. And we were discussing why would this be? Why would the highest risk group be in this 45 to 54-year-old group? And our theory is that this is the group who will be going to pain doctors, like me and other doctors, and requesting pain medication, and they will get it. And as you have already seen, there is a great deal of liberal prescribing going on, so this group gets fed a lot of opioids because a lot of them have legitimate pain issues. But there's some that don't, but there are a lot that do. So then around the year 2000, we saw the scales tip in favor of much more aggressive prescribing of opioids. 2011, the CDC finally termed this phenomenon an epidemic, stating that 100 people a day were dying from drug overdoses in the United States, most of these driven by the opioid group. So, depressingly, despite tons of initiatives at the state and national level, the problem continues to get worse. The latest data show that drug overdose deaths increased for the 11th year in 2010. So why is this the case? Why is this problem so difficult? Well, in many ways, we are looking at a perfect storm. The combination of pain, the phenomenon of pain, and the opioids makes for a perfect storm. First of all, pain is both very common and very complex. Pain accounts for about up to 80% of visits to doctors. By far the most common presenting complaint to a doctor. So doctors are barraged with pain complaints. Pain is subjective, meaning it cannot be measured. So unlike blood pressure, when you put a cuff on the patient's arm, press a button, get an accurate reading, I have no way to get an objective reading of pain. Pain is, by definition, an individual experience and is a perfect example of how ultimately we are all trapped inside our own experiences and our own mind and bodies. And your pain is your pain, and I have no way to know what your pain actually feels like. To make matters even more complex, physical pain is profoundly influenced by the patient's state of mind. So whether it's emotional distress at the moment you're feeling pain, or it's some kind of chronic issue like chronic anxiety or depression, these things have a profound influence on how you report your pain to the physician. Am I making sense? Okay. Secondly, prescribing opioids is perfectly legal in standard practice. We're not talking about something here that's out of the box. This is normal. Doctors prescribe opioids all the time. In an environment like this, though, where you've got a lot of more liberal prescribing, you're going to come up against difficult to define ethical boundaries, difficult to define legal boundaries. When, for example, has a doctor behaved unethically or illegally when prescribing opioids? Some cases it's obvious, in many cases it is not. This is why prosecution of doctors who are thought to have behaved illegally is difficult. And I've already made this point, prescription drugs, much more widely dispersed, and I would show you again this curve. when a prescription drug is unleashed, much more rapid rise in death rate than when you have a glut of illicit drugs on the market. So what's unique about opioids? Well, we take it for granted that opioids are addictive. I mean, we grow up, morphine, it's addictive. Narcotics are addictive. Well, in fact, that's an unfortunate thing because we are exposed as humans to about 30 million chemicals. 30 million chemicals we can be exposed to. And fewer than 100 of those are addictive. Just so happens that the best pain reliever out there happens to be addictive, which is very unfortunate. It also has a particularly deadly side effect profile, the opioids. They profoundly depress the drive to breathe. They profoundly depress the ability to cough. In fact, the earliest commercial use of opioids was for cough. In the late 1800s, morphine was prescribed, not even prescribed, excuse me. It was sold over the counter as a cough medicine. So just as a quick aside, the Bayer Aspirin Company, now we're talking about Bayer, the aspirin people, decided they were going to come up with an alternative to morphine that was less addictive. And they were going to sell this drug over the counter. Does anybody know what that drug was?
Heroin.
Who said that? Yes, you're the winner. The drug was heroin. Heroin, in fact, is a trade name. I mean, it's not some street name. Heroin comes from the word hero because Bayer thought that when they made this slight modification in morphine, they were going to have a great drug that was no longer addictive. They soon found out that as soon as heroin got inside the brain, it turned into morphine. So it was a horrible outcome for Bayer, and they were, I think, rightfully ashamed and embarrassed, and it was pulled from the market. So if a patient takes opioids, especially in combination with the Valium group or alcohol or another drug that depresses breathing, you get in a very deadly cycle where the brain, your breathing slows down, your brain doesn't get enough oxygen. As a reflex, the brain sends signals to the stomach to empty out everything in the stomach. Now you don't have the ability to cough. So you empty out your stomach, and the materials in the stomach now go into your lungs. Now you have two reasons not to get oxygen to your brain. You're not breathing, and now your lungs got a bunch of gastric contents in them. And opioids are the most potent substance in terms of a drug that is given to human beings in this regard. And I know this because I've practiced anesthesia for a long time, and I observed up close and personal how these drugs affect breathing and coughing and whatnot. So when a patient is exposed to an opioid, they're going to respond in one of three ways. They will either use the drug in a controlled fashion, from which they may then slip into some loss of control, which I would term as a misuse or abuse type situation. And it may progress, so these circles are smaller because most people can control it. Some people lose some control, and some people lose total control, and these are the addicts. And does anybody know what the main determinant, if you are exposed to an opioid, does anybody know what the main determinant is which would land you in one of these three categories? Genetics. So addiction is a behavioral problem, but it's driven by genetics and the neurochemistry deep inside the brain. And it's a heck of a problem to have to deal with. We also live in a quick fix culture in the United States. I was surprised to hear these numbers. Although we constitute fewer than 5% of the world population, in 2007 we consumed 80% of the world's opioid supply, 99% of the world's hydrocodone. So, we have the mentality of patient walks in the office, has pain, take an opioid. And we as a culture very much support that. We demand that. And of course, not the least important in this picture is monetary gain. Numerous parties stand to gain monetarily. At the top of the list would be the people who buy the pills from a pill mill and then go sell them on the street. The pill mills are obviously benefiting. Doctors benefit. Pharmacies benefit. Hospitals benefit. Drug manufacturers benefit. And I'm sure I'm leaving out some people. So, what can we do about it? I was asked by Jack Chapman to join the Think About It initiative, I don't know, about maybe a year and a half ago. And Think About It is different in that we are trying to take a grassroots county by county approach, because the state level and national level programs are just not working. So we need to do something different. The impact of opioid abuse involves so many different players. It's hard to know where to even begin in terms of influencing the problem. So we have a very simple approach at Think About It. We have a public component, of which Dallas Gay is in charge, largely centers around preventing diversion and proper use of the drugs and proper storage and disposal. Dallas is going to talk more about that. And a professional component, which targets prescribers and others involved in the chain of prescribing, which would include pharmacists. So, since my job is to focus on the prescriber, I'm going to talk about the prescriber briefly. So, here's an overview of prescribers. It's very simple. They are the pill mill prescribers, and these are physicians who either know or should know they are behaving in a criminal fashion. A pill mill is in the business of taking a legal substance and promoting it and selling it in really what is tantamount to an illegal fashion. It's legal, but it's illegal. The end effect is illegal. So they're in a category all their own. Draw a sharp line in the sand, and then there's everybody else. That includes me and all the other doctors around. And we all vacillate between responsible prescribing and irresponsible prescribing. And the boundaries between these two are not well defined, and it is difficult. I'm very circumspect in terms of looking at another physician and saying, that's wrong. You shouldn't have prescribed that. For all the reasons I've already been through. So there are things, though, that a physician can do right now today to prescribe more responsibly. Number one, is there a definable source of pain? This is a very, an essential question. Before you prescribe an opioid, you have to have some verifiable source of pain. I certainly don't prescribe a pill, any kind of narcotic pill, for somebody who simply walks in and says, "Doc, my back's killing me, I need Lortab." That's not going to get you anything from me. So I take a great deal of time to define the source of pain. And I'll have time to go into how I do that, but my point is, the source of pain, the doctor needs to make a good effort towards defining the source of pain. And just saying low back pain really is not defining the source of pain. Okay, the doctor needs to prescriber needs to consider all treatment options. Opioids are one of many different ways that pain can be approached. And all too often, a physician knee-jerks to an opioid because why? It's effective, and it gets the patient out of the doctor's hair. Doctors should do a very basic screen for risk of addiction, risk stratification. And this is as simple as saying to the patient, have you or anyone in your family ever had a problem with chemical abuse? Simple. If opioids are prescribed, use the lowest effective dose and the lowest number of pills. I commonly ask my patients if I'm prescribing an opioid for them. And I don't prescribe opioids for all my patients, but there are certainly some that I do. And I ask them, what is the lowest dose I can give you and the least number of pills? If I got a patient that tells me, you know, doc, I need oxycodone 15 milligrams, about 120 pills. That's not a good sign. But if somebody says, I can't remember, it's hydrocodone or something like that that's worked for me before, I don't remember the dose. I like that, because that tells me the patient knows very little about narcotics. Of course, even then they could be pulling a scam on me. But generally speaking, when a patient acts ignorant about opioids, they generally are ignorant about opioids. If you do prescribe opioids, you need to educate the patient about the risks and benefits of opioid use. You need to remind them that sharing your drug is not legal. And you need to remind them about how to properly dispose of the medication. Finally, and this is absolutely critical, if you don't do any of this stuff, you got to do this. Once you've prescribed the drug, you've got to monitor the patient and see how they handle the drug. If you give them whatever number of pills, which you expect to last 30 days, and they call you 10 days later and say, I'm out, I need more, major red flag that warrants further investigation. Monitoring is very important. So I return to the question of balance. And what confronts physicians, prescribers, is we have to provide patients access to opioids for legitimate pain-relieving purposes. And there's a lot of legitimate pain in the United States. We have to balance that against overprescribing and the subsequent diversion that results in the unintentional deaths that result from diversion. Thank you.